Good morning, Keith Tebow from FRCmedia. Thank you for joining us today. It's been a little while since we've talked about COVID-19 in terms of the virus itself and how it's impacting not only the country, but in our region. So we thought we'd reintroduce you to Dr. Erin Bromage. Dr. Bromage is a associate professor of biology, specializing in immunology at UMass Dartmouth, and we've spoken to him before. Dr. Bromage, thank you for joining us again. How are you?
I'm doing very well.
I want to get into, a lot of talk has been around the Delta variant. It's been dominating the news as we speak in terms of the number of cases of COVID and how they're expanding across the country. We've talked a little bit last time you spoke about variants. I want to ask you specifically about Delta so people can understand how contagious is it in relation to the other forms of COVID that we've spoken about? And how does it compare in terms of its level of being contagious with things that we deal with, like the common cold and the flu that many of us have experienced?
Yeah, so this new variant is definitely, from a viral perspective, a new and improved bug. It has the main thing that makes this one a little bit more effective is that it is more efficient at being released from our cells, especially in our mouth and our nose. So we're finding people that are infected with this variant and are at the infectious stage where they can actually spread it and give it to others, are carrying around about 1,000 times more virus in their mouth and in their nose. And because this is a pathogen that is actually spread through breathing, talking, singing, it's breathed into the air, put into the air. More virus in your mouth and nose means more virus put into the environment, and so more opportunities to infect other people. So that there has sort of changed, not the game completely, because it's still spread through the air, but it does mean that more virus is being put into the air. So what we're looking at now is where originally the original variant, one person would have infected about 2, maybe 3 people. Then we had the alpha variant that originally described in the United Kingdom that could infect maybe 3 to 4 people. This one is close to 4 to 6 people. They did talk about getting up as high as 9 people, but I think the circumstances need to be really unique for that to actually happen. So we're looking at one person infecting 6, and why that matters is 1 infects 6. Those 6 infect 6, so we're up to 36. And then those 6 infect, and those 36 infect another 36, and it gets really big really quick. That's why we're seeing Delta move through the community much faster, even though we have high vaccination rates.
And again, let me just ask you, how does that compare to, let's say, the common cold and how that is spread? Things that, many of us, deal with on a consistent basis, and even the seasonal flu. Well, how can you make that comparison if you can?
Yeah, so when we look at, say, seasonal flu, we're looking at one person infects about 1.2, 1.3 people. So, if we're looking at an average of about 6, it's a lot more contagious. The common cold, I'm not sure of the numbers of the common cold with that. Chickenpox is around about 9 to 12. Measles is about 18. So it's moving up there into some pretty highly infectious, pathogens that we currently are exposed to. So it is one of the more efficient respiratory pathogens that we have out there at the moment when we're looking at things that are infecting us.
All right. There have been, I was on the World Health Organization website today, and, there are other variants that are making appearances. Obviously Delta is the one that has been on the forefront here recently, but there are others that have been sprung up across the world. What is the likelihood of some of those other variants? I heard of a Lambda variant. What are the likelihood of those making headway across the world and here in the United States?
Yeah, well, viruses, like when that virus gets inside you, even if it's just one single viral particle, if it establishes an infection inside you and starts making more copies, there is literally going to be tens to hundreds of different variants, like mutations that take place in the virus that's inside you. So as long as we give this virus a host, new variants will emerge. Now, sometimes those variants don't provide any advantage for the virus, and so it dies out inside you or never gets transmitted. Others are neutral, make no difference at all, but sometimes it confers an advantage for the virus. So, for example, it might be released from the cells easier, making more virus in the mouth and nose, making it easier to transmit. It may improve its ability to survive in the environment, making surfaces more of an issue. It may grab hold of our cells better and get into our cells easier. So there's a whole bunch of different things that the virus can do to become fit, but there's also a lot of things that the virus can do that make it less able to infect. So what we're seeing is this just wave of different variants come out in different regions, especially where there is big outbreaks. So we have the Delta that appears to have originated in India in the very large outbreak that they had, and then has spread and become dominant throughout literally the entire world. But because we've done such a poor job here in the United States, that Delta variant has now changed, and we've got a new Delta variant that is emerging in the Northeast. And we need to look at that. We need to see why it is expanding in numbers compared to other variants. Now, the Lambda variant is going to be, one that we definitely need to keep our eye on. It was originally described in Peru, so we're in South America, and it seems to have many of the same qualities that the P1, the beta variant that originated in Brazil had, which is immune escape. So we saw that with that P1 variant, that people who had been previously infected and people who had been vaccinated, they had a lower level of protection than what we would have expected based on the alpha or the original variant. So, if that virus changes enough and our immune system can't see it correctly, previous immunity is not as good. And that appears to be what's happening with this Lambda variant. So Lambda and P1 both are, but we've seen the P1 get into the US and it didn't do very well here, compared to the Alpha or compared to the Delta variant. So it comes down to, a unique adaptation that the virus makes and whether it is suitable for transmission in both the environment and the people that it needs for hosts. So I really want to keep Lambda out of this country. We are seeing a few cases pop up. It's in a number of states right now. That doesn't mean it's going to sweep through the country. It means that we need to keep an eye on, we need to keep doing the surveillance of the viruses, the genomic surveillance to know what we're dealing with. And just a little bit fingers crossed that we don't let that one get out of control here. We don't know enough about it yet, but it does look a little worrisome.
Let me get into a little bit about vaccines. Many of us have been vaccinated, and that has helped in terms of stemming the tide from, about February, April through this current period where we are seeing spikes. Is it troubling that, so many of us are vaccinated but we're still able to, and we've known this from the beginning, we're still able to contract the disease. We may not exhibit any symptoms or may even not get sick at all or have mild symptoms and be able to pass it on, especially during this Delta stage. Is that troubling in terms of, getting a hold on how this thing continues to spread?
It's not troubling. It was expected. But keep in mind that we have pathogens that are, measles, that is at least twice, maybe 3 times more contagious than this particular pathogen. And vaccines work. And we only have about 300 cases per year. So the big difference there is we have great vaccine coverage, which makes it much, much harder for the virus to find a home. So our problem at the moment is, it's not trying to label unvaccinated and vaccinated, but as long as we make it easy for the virus, which is an unvaccinated host, we're allowing it to just roll through the community. And then when a infected person, particularly an unvaccinated infected person, gets into an enclosed space with, it doesn't matter if they're unvaccinated or vaccinated, they're putting out a large amount of virus, and that can actually break through the wall of immunity. So immunity is not binary. It's not immune or not. It just enhances or increases your ability to fend off an infection, but at some stage it can be overwhelmed. But it's important to realize, yes, when you are vaccinated, you can be infected. But the really important thing is at what rate compared to being unvaccinated. And the general side of things looks like you've got about an 8 to 50-fold increase in protection compared to an unvaccinated person. So there was beautiful data that has just come out this week from San Francisco, showing vaccinated versus unvaccinated, the risk of testing positive, and not even disease. This is just testing positive. And there's an 8.8-fold difference between vaccinated and unvaccinated. And then Kaiser actually put out a report on about 30 states that are reporting positive cases and breaking them up into vaccinated and unvaccinated. And we're seeing in the vaccinated group, at the worst, they're accounting for about 5% of all new cases, and an average around about 1% of all new cases. So unvaccinated are accounting for, let's just say, 99% of all cases. And it's even more with hospitalizations and death. So vaccines really work. So when they ask the question about, can you be infected if you're vaccinated? The answer is yes. But it's important then to look at, yes, but how likely is it? And it's incredibly unlikely. You then look at, can you transmit if you're one of those unlucky or unlikely people? And the answer is yes. Again, in the situation where in closed space, long period of time, no masks, there is the potential you can transmit to other people, but the likelihood is very low because of immunity that you have, antibodies in your mouth and nose that stop it from being released. We've seen that people who are vaccinated and infected, they clear the virus sooner. So we're not in that infectious period for as long. So, technically, yes, you can be infected and infect others, but the relative risk really needs to be looked at when we're thinking about those things.
Mm. Are we, and I'm using a term that I'm creating here, are we at peak vaccine? And what I mean by that is, when the vaccine came out, those people who were eligible, who were interested in getting the vaccine, got it all at once. It was a great surge. The numbers were fantastic. Obviously, we've hit a wall of sorts in terms of the number of people getting vaccinated. We hear about the political side of things, on how some people of certain political persuasions are just not going to get the vaccine, and we have to deal with that. I guess my question to you is, one, are we at peak? Is there a way to even nudge it even higher to get to a potential herd immunity? And if not, how do we still potentially maybe get there?
Yeah, so we hit a wall about 3 weeks ago where it was, very moderate increases in new vaccinations being given. But this is very typical in any vaccination program, is that you hit this wall of sort of resistance where people start to worry more about vaccine side effects than what they do about disease side effects. And so there's this hesitation period. And then what we see, and again, this is not unique to SARS, but this is unique to many different pathogens where we have vaccines for them. When there is an outbreak, hesitancy against the vaccine goes away. And in the last 2 weeks, we've had an incredible surge in the number of people seeking out first-time vaccines, especially in communities that are getting quite hard hit at the moment. So we're seeing vaccination rates start to increase in Arkansas, in Missouri, Louisiana, Alabama, even in Florida, it's going up there. But again, it's not going up fast enough. But there is a real tidal wave of things that are about to happen. So in the next 2 weeks, we would expect full FDA approval of the vaccine. That was announced last night. Dr. Fauci talked about it. We're seeing that it's really going to move through now a bit faster. So that will give some people a little bit of confidence that it's no longer experimental, but it's approved. But getting fully approved vaccine also gives employers cover to mandate it in the workplace. And I can tell you from previous experience with this particular pathogen, when an employer mandates the vaccination, the resistance to getting vaccination goes away because people want that job. And so I've seen organizations that had 150 people, 21 of them not vaccinated, employer mandated. We only have one person unvaccinated, and it was for a medical reason. So I think we're about to see a tidal wave of employers, of organizations saying vaccination is required to work here or attend here, with the only exceptions being religious and medical, depending on which state that you live in. There are some really big changes about to happen with that. And I think that that will drive the new wave of vaccinations that get us a little bit closer to making it a safer community.
Yeah. Yeah, I know you have worked with a number of entities and organizations in terms of how, they need to deal or could deal with the virus as they begin reopening. There's, still a large number of companies that employees are still working remotely. When you speak with them in terms of how they can make their workplace safer, do you talk about, air ventilation and how that can be improved? In combination with, depending on vaccination status, in combination with, say, mask wearing and social distancing and vaccinations? I guess, how do you work through that when you're speaking to companies that you can assure them that they can be safe to reopen?
Yeah, well, we can never assure. All we can do is highlight the risks and point out strategies that we can use to lower that risk down. There's never a 100% safe environment, but we also know life is not 100% safe. So things that we focus on is making sure that if an infected person does come into our space, that we make it as hard as humanly possible for that virus, that infected person, to infect other people. And because infection is through the air, it's shared air, it's aerosol, it's airborne. We really need to focus on that it's in the air. We need to focus on improvements to the indoor air quality. And that can be through ventilation, so getting the air from the inside out and the air from the outside in. Filtration, so putting in good filters in place that strip the air of small particles. Or masking actually adds another layer to that because it stops any virus going out into the air. So we look at those strategies. We look at the density of people that they have in those places. If density is high and vaccination rates are low, we may implement testing. So it's a lot of different layers that we put in place. It would be very silly of employers right now to go back to work and only rely on vaccination as the level and high levels of vaccination to protect their workforce. You need to have vaccination and good air quality, or you need to have good air quality and some testing. Because at the moment we're not looking great as a nation. So the Northeast is looking pretty good, but we know we're in for a rocky winter. So we need to be prepared to provide a good, safe, or as safe as we can make it, indoor environment for people.
And that actually leads me to my final question: putting getting out your crystal ball and looking toward the fall and the winter. Is there an expectation of surges, and how can you even gauge that with some people being vaccinated, and that leads again to potentially how long the vaccinations will be effective in us? I guess, what are you looking for as we head toward the fall and winter months?
Yeah, so the surge that we're seeing in the southern part of the country was completely expected. We saw the similar thing happen last year. When it gets very hot, it changes people's behavior. They get driven inside, they close the windows, the doors up, turn air conditioning on, and that provides the environment that the virus really likes to be able to transmit between people. So this surge that we're seeing, the magnitude is higher than we hoped, but the timing of it was pretty much in alignment with what was expected. I have to admit, I did not expect the bump that we're going through now in the Northeast. This is really Delta that is driving this. This should have been a fairly easy period for people living in sort of the nice, warm weather, but it's not driving you inside all the time. A lot of outdoor activities should have led to lower infection rates up here. So it's a little bit surprising what we're seeing in the Northeast. But what we're looking at, and its history dictates this, that in November, around about mid-November, we are going to get challenged again. So when we look at the seasonality of respiratory pathogens, particularly the 4 human viruses that are already in our system, in our population, around about the second week of November, they start to go vertical, straight up in regards to infections in the community. And we saw that with this coronavirus as well. And that, again, is about the time seasonality and behavior changes that drives people from outdoor activities to indoor activities, windows and doors shut up, not great ventilation and filtration, and that just provides the right environment for the pathogen to find a lot of hosts. So we should not expect a surge like we saw last November through to February. That was, unvaccinated population. The only real protection that we had there from a physiological basis was previous infection. This time around, the vaccination side of things, the very high levels that we have here, is going to blunt the surge that we have. And so it's just a matter of how high this actually gets. I do see extra mandates coming in, masking. There might be vaccination mandates coming to try to control that surge in November. But I think that if I was a betting person, crystal ball, November in New England, December, January, we do need to be mindful of what's happening there and not let it get out of control. Now, the durability of vaccines is a big question that a lot of people have. We can't know how long they're going to last for until time has passed. So Israel is sort of a leading indicator at the moment because they got a lot of their population vaccinated very, very early in the year. And they're up to that 6-8 month range for a vast majority of their, especially elderly population. And they are seeing a little bit of waning in immunity in those people that were vaccinated in January and February. But they're looking at, say, with the mRNA vaccines dropping from 95% to around about 85%. So we're not dropping that much, and that's actually pretty good. And considering that those people that were vaccinated early were the older, more frail, immune system not quite as robust people. So what I tend to think that's going to happen it may actually happen quite quickly that we hear it. San Francisco, again, was a leader with this. People that got, say, the J&J vaccine, I think we're going to find that there is a recommendation that people that got the single J&J go out and get a single shot of a Moderna or a Pfizer vaccine to boost them from 77 up to 95%. If that was me, I would be doing it in September, October to give me the best immunity I possibly can have to get me through November, December, January, February. And then people that had the mRNA vaccines, I tend to think we're going to see a recommendation for boosters for people that are immunocompromised, that are maybe organ transplant, definitely people that are over the age of 60, 65. There's going to be some sort of age they pick. Anyone above that, we recommend a booster shot in. And again, I think that will be around about September. They're asking it so that you actually have peak immunity, which occurs about 2 months after vaccination. You have peak immunity starting in November. For the rest of us that are otherwise healthy and had our shots in March, April, May, I don't see the need based on the data we're seeing now for a booster at all. Yes, it does drop down, but that's expected. And we're really trying to stop mild, moderate, severe disease, and they seem to still be doing a really remarkable job. So I don't see that changing for the vast majority of Americans this year for a need for a booster. It'll be select groups.
All right, Dr. Erin Bromage, as always, I appreciate your expertise. You always explain it in a way that we can all understand, and I totally appreciate that. We'll talk again soon. Thank you for all your help, and have a great rest of your summer. I appreciate it.
Thank you very much for having me on your show. You have a great summer too.
You too. Thank you.
Bye.
And that'll do it for FRC Media today. I'm Keith Tebow. Have a great rest of your day.